Hi, very good evening to everyone. I thank the organizers for giving the opportunity in this wonderful meeting. And we have heard TAVR a lot. Something slightly away from TAVR is the pulmonary valve. So my topic is going to be a transcatheter pulmonary valve implantation in a native pulmonary artery. So that's something we want to discuss shortly. So disclosures, as you said, just for you. So background, the prevalence of congenital heart disease and is increasing and is growing up. And if you look at the commonest anomalies, obvious anomalies, and PR increase rate at 22 years, we see PR, and we often delay the surgery due to the morbidity involved in surgery. And so, but irreversible RV dysfunction is something we do see nowadays a lot. And so we are looking at a category of patients who are be exposed to pulmonary regurgitation for a long time and having severe RV dilatation, and we do delay pulmonary implantation for a considerable amount of time. And so something, a discussion going on to see whether we should intervene earlier for all these pulmonary regurgitations. So already look at the tetralogy fallow and other group of obvious anomalies. We have two groups where basically where we go, surgeon goes and patches the RVOT, which causes free pulmonary regurgitation. The next one is you put a conduit across RVOT, causing giving connection from RV to the PA. So those are the two categories of surgeries being done. So for the RVOT for the conduit category, usually they do have a calcification and have severe stenosis, where we go and implant a stent to get rid of the obstruction. And then we finally go on to implant the valve. This is a case of my valve, which we implanted the first time in India for a pulmonary position, which is a native pulmonary artery, and a very good result post deployment. So that's very straightforward. We did balloon dilatation test for coronary arteries also. So here we do have a landing zone clearly, and we do implant the valve there, and there's a good radial force to hold the valve. But the category which I want to discuss today is a category where we have a surgeon patch the RVOD and the PA, where we have a huge channel patch, and how are we going to deal with this? Unfortunately, 80% of all RVOD surgeries been done have got this anatomy. So that's something we're going to discuss today. So what are the valves available for pulmonary valve implantation? Melody valve is a custom-made pulmonic valve, which was found in 2000 by Philippe Bonhoeffer. And but the difficulty with Melody valve is it's only into the conduit, not to the native PA, because the largest size available is 24. The Sapiens been in the aortic position. We've been using it in the pulmonary position. And the MyValve recently been introduced. This is balloon expandable valves. Self-expandable valves is a harmonic valve, Medtronic, which is going to come into the market soon, and Venus P valves already in, and which is the Venus Maytech company. So looking at the self-expandable valves, which we are using in India's Venus P valve system, which is basically has got a central cylinder portion and outflow, expanded outflow and expanded inflow. And the valve is a central cylindrical portion. And there is a valve diameter incremental from 16 to 36, the 2 mm increment. And you have a flare diameter approximately and distally 10 mm flare, and it goes through a 20 to 24 French sheath. So you look at this valve, this is the way it's implanted. It's a 22 French sheath, and the valve sits in the RVOT like that. And publications recently, early experience has shown promising results that it can be safely and effectively done in implanted in native pulmonary arteries. But the disadvantage of this technique is stenting RVOT can prevent the RV remodeling, and stent fractures, particularly low end, and availability, particularly in India, has been a difficulty getting this venous self-expandable valves, and that's the situation here. So the concerns of large valves is huge RVOT because of the loss of energy by eddy currents, and RV muscles all stented. And as I said, it can prevent the RV remodeling. So what are the challenges we have in balloon expanding valve? Large PA diameter, we cannot do a pre-stenting because there is non-availability of a large, long braided sheaths which can go beyond the pulmonary valve, and foreshortening is an issue, and stenting as such, putting a valve after stenting can cause embolization of stent. So there's a huge difficulty in getting a huge stents, like more than 28 mm stents across the RVOT. And elasticity of dilated PA, difficult to choose the right diameter, which can be, it can be higher, it can cause a PA rupture. If it's lower, it can cause embolization. And largest diameter valve available is 30 mm. That's the sort of limitations of a balloon expanding valve. So what is available now is we have Edward Sapiens, which is the largest of 20 mm, and Melody valve, which is 24 mm, and my valve, the largest size 32 mm. That's something edge over Sapiens valves. My valve, we have as a 32 mm valve, and it is useful for implanting large RVOTs. So we looked at a paper done recent in 2019 regarding Sapien valve without pre-stenting, and by this we sort of started to do this procedure. So important thing in a native RVOT is identifying landing zone in a CT scan, and we should make sure the landing zone is not more than 30 mm, and the coronary artery anatomy and the proximity of landing zone to branch PAs and calcification if any. So landing zone definition is basically looking at narrowest point where we can deploy the valve. You can see here, we look at the systolic frame of multi-slice CT, look at the narrowest diameter, we plan it up, and if the diameter less than 31, we can go for implantation. So here you can see an index case where we can see severely dilated PAs in AP and RA view, it's a severe PR. We cross the RVOT and position the wire deep in the LPA. That's something very important to have a Lundagus wire in the LPA. Then we go for balloon sizing. Here, if you see the catheter, we use it's a ZMED balloon 30 mm. We go for inflation. We do a RV angio, look for no outflow tract, and also look for the coronary also. So look, both the testing has been done. So there's no outflow across the RV. There's a mild vase is there. There's no coronary anomalies. So we can go for it. So this lady had a diameter of 28. Then we went for a 32 mm valve. The valve is taken across the RVOT. We started pacing the heart at 250. So we did injection initially and went for inflation. We do a very, very, very slow inflation so that we make sure that approximating at the landing zone. So here we see we are going very slowly. We're doing one more injection halfway through, making sure we're going to approximate, and we go for the final inflation. And here post dilatation, we make sure the coronary arteries are normal. We got a coronary wire across the nearest coronary artery. So here you can see there's a post implantation angiogram showing good stable position of the my valve. It offers good grip across the pulmonary artery and good result post. And this lady is 2 years follow-up, and this is the result now, 2 years follow-up. Now there is no mild PR, no obstruction, and she's doing well. So this is one more case where you can see that how to identify a landing zone. The two zones are seen, one calcified zone, one the top, there is no calcification. But we look at the top zone and it fits with the criteria of having a mean diameter of 30 mm. The lowest one was huge. So we decided to go for the one and superior landing zone. So you can see here, as the CT suggested, the two zones of narrowing, one the top, one the bottom. So we went for the balloon sizing, and you can see the balloon sizing showed a narrowing of 26 mm is the diameter, and there is no forward flow. So we took up the valve here again. It's a 27, so we took a 30.5 valve here. And we went for the full inflation as usual. We did a very, very slow inflation, and the valve sat well, and post deployment angiogram showed good result. So this is a paper in press we published saying how we are going to choose the right size for the balloon expanding valve from pulmonary valve. We indexed 3 patients. These are the 3 patients who had tetralogy fallow surgery with transannular patch. And what we saw is the balloon sizing is the CT scan screens to look at the narrowest diameter, but balloon sizing gives you the correct diameter for you to go implant. We actually increased the balloon sizing by 20%, 20 to 25% by achieving a stable valve position. So conclusion, we said that it's feasible to do large native PA without obstruction using new my valve, and but we have to recommend 20-25% increase in balloon sizing to achieve a stable valve position. But precautions, PA rupture is a major concern as TPA is elastile, always it accommodates a big valve. But what we have to be sure is we should have a stent graft, which we have a Medtronic stent graft, 20 to 36 mm available in the shelf. If in case you rupture the PA, so you can put a graft across the obstruction. Coronary occlusion, always have wire across the nearest coronary. Very, very slow inflation. Inhalation always under pacing. And TPA can be done, and we can do up to 31 mm mean diameter. A CT scan to assess the landing zone is very important. PA rupture, always have stent graft available in shelf. Coronary occlusion, have a guide wire and catheter across the nearest coronary. So ending the thought, the pulmonary regurgitation is not a benign lesion. We ignore it for a long time till the RV dilates. And I just throw a question saying, should you consider early TPA for before the landing zone expands a lot? Thank you for listening. Thank you.
Wire inside and sedation, I think anesthetic is giving extra sedation. So one has to be careful, and these are reversible causes.
Yes.
And what would you do if there is hypotension? Would you correct it before putting the valve, or you would put the valve anyhow? Supposing there is hypotension and the patient has critical AS. You're not audible. You're not audible.
Yeah. The hypertension is not mechanical. Like we haven't had balloon dilatation prior. We are more comfortable correcting the blood pressure with small dose of NORAD. The patient has a critical AS, patient has EF of 30%, patient is unlikely to improve. With correction, we tend to dilate, do a BAV for hypertension. But otherwise, if the patient is not a very critical AS, no dysfunction, we actually more comfortable improving the blood pressure before we go in.
No, but with a critical AS, and
we actually we did one patient like this. Critical AS, as soon as the anesthesia gave GA, this is the second or third patient. After GA, patient actually crashed to 80 blood pressure. So we didn't do anything. So we actually did a balloon first, then the pressure improved. Your point is well taken, sir. When the critical AS dysfunction, sometimes relieving obstruction also is a therapeutic hypertension.
Yes, that is what I. Any
all from our last experience in 50 cases where we had hypertension, the various points, but for anti-dilatation, we had almost all of them. It's simple in interventional cardiology. The more you do, the higher complication you get.
Any other point? Ramesh, you want to say something? Are you there?
No, I had very well covered the causes of hypotension post-TAVR by Dr. Gokul Reddy, and I think this is really important to know how to approach whenever we have these patients who could be suddenly deteriorating. And both Dr. Goel has shown a fantastic iliac case complication. And here, coronary obstruction, cardiac tamponade, aortic annular rupture, all of them are the things that we need to be concerned about. And obviously being prepared for the worst is always a good thing, and having vascular surgery or even cardiac surgery next to us is important. Thank you, Dr. Goel, and thank you, Dr. Gokul Reddy.
Yes, sir. For aortic position, I would always use a supraannular valve. Number two, patients with smaller annuli, like the example which I showed, smaller annuli and obese patients, I was always use a supraannular valve. And third one, we don't know, patient might require a 23 millimeter balloon expandable, but might fit into a 29 millimeter self-expandable, and patient is young. So again, we don't know, we have to wait. When the larger the size of the valve, will it last longer compared to the smaller valve? We know from the surgical population that a larger valve lasts longer than the smaller valve. But as of now, for valve-in-valve, smaller annulus and obese patients.
Okay. How about cracking the valve-in-valve? Will that be better, or putting with the same annulus, putting a supraannular will be better?
So you put a supraannular valve and then crack, sir. Still, you'll have to put a supraannular, because even if you crack a 19 mm valve and you put a 20 mm balloon expandable, your hemodynamics will still be poor. It's more like you optimize the frame. So you put a 23 millimeter valve and then you crack.